Thanks very much, Rahul. So my name is Karen Walker. I'm a clinical nurse consultant at Royal Prince Alfred Hospital, and I'm the president of the Council of International Neonatal Nurses.
Recording in progress.
I'm delighted to welcome our two speakers today, Ms. Keiko Suzuki, who's the chief nurse of Tokyo Metropolitan Hospital, and Professor Miki Konishi, who's a board member with us in COIN and a professor of nursing at Dokkyo Medical University, Japan. Now, their talk today is on daily challenges in caring for the very tiny babies. And I think Japan has some exceedingly good outcomes for these babies born at 22 and 23 weeks gestation. So we are really interested to hear how you care for them because they are very challenging to care for. So I might hand over first to Keiko. We'll stop sharing, and Keiko, you should be able to share your slides now. Let me know if you've got any problem sharing. Fantastic. Great. And over to you, Keiko. Thank you so much for joining us today.
Yeah, thank you.
Yeah, you just need to make it full screen.
Oh, okay.
Great. Thank you.
Thank you. I'm okay. Let's start.
Yes, please start.
Okay. Hello, I'm Keiko Suzuki. Today, I'm going to talk about daily challenges in caring for very tiny infants in Japan. I work as a neonatal intensive care certified nurse in the Tokyo Metropolitan Ohtsuka Hospital. At first, I'd like to introduce the Tokyo Metropolitan Ohtsuka Hospital where I work. Ohtsuka Hospital is in Tokyo, located in the northwestern part of Tokyo. It is a general hospital with about 500 beds, designated as a perinatal medical center. It has 15 NICU beds and 30 beds of step-down NICU called GCU. The medical staff consists of 12 neonatologists, 3 pediatric residents, 39 NICU nurses, 39 GCU nurses, and 1 neonatal intensive care certified nurse in the NICU. A maximum of 1 to 2 babies are assigned per nurse on day shift and 3 babies on night shifts. In the GCU, a maximum of 3 to 5 babies are assigned per nurse on day shifts and 6 babies on the night shifts. Ohtsuka Hospital was renovated and reopened since December 2022. We have automatic lighting that matches circadian rhythms, partition on each bed to ensure a private space, reclining chairs for kangaroo care for a more relaxing experience, and negative and positive pressure rooms for surgery. Introducing the characteristics of newborns admitted to Tokyo Metropolitan Ohtsuka Hospital. In principle, we accept all newborns after 22 weeks of gestation. However, newborns with congenital heart disease that require surgical treatment immediately after birth are excluded. In addition, our hospital is characterized by high acceptance of maternal transport, low birth weight infants, and socially high-risk pregnancies, such as unmedicated single welfare. This table shows the performance of the obstetrics department. The number of deliveries is around 900 per year, including multiple pregnancies such as twin. Maternal transportation cases account for around 20% of all births. This table shows the performance of the neonatal department. About 500 newborns are hospitalized annually in the neonatal department. Approximately 15% of all deliveries are preterm birth. About 10% of them are under 1,000 1,500 grams. In addition, about 10% of newborns with respirators other than CPAP. From here, I'd like to talk about today's main theme, caring for very tiny infants. The baby in this photo was born at 23 weeks of gestation. This shows the scene of resuscitation. All babies are resuscitated on radiant warmers in the delivery room. Premature birth resuscitation is performed by neonatologists and midwives. Our hospital does not have a system in place for NICU staff to intervene in resuscitation, so we are preparing to accept premature babies in the NICU. At first, keep warm during resuscitation. We use plastic bags during resuscitation for all infants born under 28 weeks of gestation. This plastic bag is a product called Nail Help from Vegan. We sometimes use Saran wrap. We prepare a plastic bag on top of the radiant warmer. Then move the baby inside the plastic bag. After resuscitation is completed, we move the baby to the NICU using an incubator for transport. We prepare closed incubators in the NICU. Incubators are set up and prepared according to gestational age and expected weight, as shown in the table. We continuously measure and control body temperature. Temperature adjustment of the incubator is carried out by manual control. A temperature probe is placed between the mattress and the back for 24-hour continuous monitoring to prevent hypothermia and hyperthermia. For premature infants under 28 weeks of gestation, we set the incubator to high humidity, 70% or more, for 72 hours after birth. This is to maintain body temperature is controlled in sensible perspiration. Then the humidity is lowered to 60% around 2 weeks after birth. NICU nurses practice skincare for newborns while discussing with nurses who specialize in skincare. We evaluate the maturity of the skin and discuss about the care method for the humidity, preventive care, and so on. Very low birth weight infants keep supine position for the first 72 hours to prevent IVH. Use mattresses designed for low birth weight babies to prevent pressure ulcers. This mattress is made of urethane foam material and has excellent body pressure distribution. Special non-woven sheets are used for mattresses. No skin injury caused by this sheet. For 72 hours, it is prohibited to change the position, including the position of the head. So the mattress is pushed by hand to release the pressure at the timing of care. In addition, newborns with an arterial line do not use an ECG monitor. This is also intended to prevent skin injury on the chest. Applying the SpO2 probe directly to the infant may cause skin abrasion. So a non-adhesive silicone gauze is applied to the probe. This will prevent the probe's adhesive from coming into direct contact with the infant's skin. And we do not bed bath until about 1 week after birth. Respiratory management. For the first 72 hours after birth, a sedative will be used for respiratory control. This is for IVH prevention. We use fentanyl to sedate infants born between 22 and 24 weeks of gestation for the first week after birth. In addition, caffeine preparations are used for ventilator withdrawal. Ohtsuka Hospital does not have clear standards for starting use, but nurses monitor the infants at the bedside 24 hours. So we make suggestions to the neonatologist according to the condition of the infants. For the ventilator setting, select SIMV mode at first and change to HL4 mode according to the condition of the infant after 1 to 2 weeks after birth. Consider changing to non-invasive continuous positive pressure ventilation around corrected age 30 weeks. Nurses can adjust the inspired oxygen concentration within the limits of the neonatologist's orders. Nutrition. At Ohtsuka Hospital, we promote breastfeeding. The goal is to start pumping within 30 minutes after delivery, and the breast milk immediately after birth is delivered to the NICU by midwives. Breast milk is applied to the oral cavity of the infant according to the condition of the infant. We also use donor milk with the consent of the family. Oral feeding practice of premature babies can be started around corrected age 34 to 35 weeks, even if non-invasive continuous positive pressure ventilation is used. Infants with chronic lung disease tend to start oral feeding later because their respiratory status is unstable. Pain management. Pain management. In Japan, Four Society jointly created pain care guidelines. This guideline is limited to acute pain associated with bedside procedures routinely experienced by neonates admitted to the NICU. Currently, post-operative pain is not included. In Japan, each NICU provides pain care based on this guideline. Non-pharmacologic palliation is the first choice for painful procedures such as heel sticks and venipuncture. Neonatologists and nurses are paired for blood sampling, ultrasound, and so on. For example, when collecting blood, neonatologists perform the puncture and nurses do non-pharmacological pain management such as FT and NS. Family involvement. Parents have access to their babies 24 hours a day, excluding nurse handover. Mothers can see their babies from the day they are born, if their condition is stable. After the acute phase has passed and the newborn's condition has stabilized, they participate in care with the support from a nurse. The average length of time a family stays in the NICU is about 4 hours. Most mothers can come to the NICU between housework and childcare for siblings. Families carry out routine newborn care such as FT, changing diapers, bathing the infants. Ohtsuka Hospital used to allow visit by grandparents and siblings, but due to COVID-19, it is temporarily not allowed. Recently, grandparents and siblings can see the babies online. Kangaroo care. In Japan, kangaroo care initiation criteria and implementation varies by each NICU. At Ohtsuka Hospital, kangaroo care suggests to neonatologists to start by that time, based on newborns who are corrected age 32 weeks and weighing more than 1,200 grams. Most kangaroo care is started after about 2 weeks after birth. We do not provide kangaroo care during intubation because of reason for patient safety. It is carried out for neonates after non-invasive positive pressure ventilation. At Ohtsuka Hospital, we will coordinate with families to provide kangaroo care for at least 1 hour. If the family wishes, it can be carried out daily at the bedside. After kangaroo care, we have an environment where mother can pump at the next to her babies. Nursing education. 3 to 4 newly nurses are assigned each year. Each newly nurse will be supported by 1 mentor for 1 year. At least 5 years of clinical experience is required to become a mentor. At Ohtsuka Hospital, care for newborns is provided by 2 nurses. During the day shift, 1 nurse will care for 1 to 2 newborns. Nurses share the data about each other's infants. During the night shift, 1 nurse will care for 3 infants. In partnership nursing system we call PNS, nurses share care method, timing, and precautions. Nurses often provide care alone for less critically ill babies. Here, I'd like to introduce the dedication of newly nurses at Ohtsuka Hospital. In the first year, they learn basic care of newborns and nursing of CPAP-equipped infants. In the second year, they learn to care for stable intubated infants, including very low birth weight infants. In the third year, we aim to implement acute care for extremely low birth weight infants and acute care for 22 to 23 weeks of gestation. Newly nurses receive support not only for the first year, but also continue to receive support as needed until they have acquired the skills they need to acquire in the NICU. Because we work in pairs to practice newborn care and learn from each other. In Japan, there is a certification system for nurses who specialize in nursing newborns. After 1 year of specialized training, they will be certified by passing an exam. 5 years of clinical experience is required to be eligible for the CNNIC training program. 3 years of experience in the neonatal department is required. CNNIC must be renewed every 5 years. The CNNIC program is offered only by Dokkyo Medical University. Certified nurses have 6 competencies. For example, promote developmental family-centered care, advocate the rights of newborns and their families. Finally, I present a case study on incubator humidity. Ken was born at 22 weeks of gestation. He was born very immature. We set the incubator at 38 degrees and 90% humidity. His skin was gelatinous. An umbilical catheter was inserted and sedation was initiated using fentanyl. I'd like to introduce basic care at Ohtsuka Hospital. Very sorry, this baby is not Ken. I don't have a picture of him, but his skin was much more immature. During resuscitation, Use a radiant warmer and a closed incubator in the NICU. Adjust the humidity in the incubator after the conditions have stabilized. Humidity should be changed by 2 to 3% at a time and should be adjusted mainly at night when there is less treatment. This will minimize the impact of the baby's body temperature. We visually assess the skin condition. For example, observe the degree of stretch of the skin and guess the dryness level of the skin. Of course, we check the data and assess the general condition. Apply a small amount of petroleum jelly to areas that are extremely dry. There are skin injuries in areas where the skin is in close contact with the skin, such as the armpit and groin, and in areas where the skin rubs against each other due to body movement. Let's go back to Ken's case. Sorry. Okay. He had a congenital heart disease. He was very respiratory and hemodynamically unstable. Therefore, the body temperature was also unstable. His body temperature was greatly affected by the thermoregulation of the incubator. He suffered skin injury on his chest and arms due to friction from his own movement. With the use of allogeneic dressing called algodon chorionic from Smith and Nephew, it improved in about 10 days. It was possible to lower the humidity from about 6 days after his birth. Humidity was about 70% at 2 weeks after birth and about 60% at 3 weeks after birth. This table shows the progress of incubator temperature and humidity up to about 3 weeks after birth. Skincare for very low birth weight infants is also influenced by the condition of the newborn. There is no fixed care method even in Japanese NICUs, and various methods are practiced in each NICU. I'd like to finish by thanking you all for listening. Thank you.
Thank you, Keiko. Really interesting, and lots of questions coming and comments in the chat. Miki, are you online? Has Miki joined us?
Yes.
Yeah.
Yes.
Do you have some slides or some comments here?
Yes. We have many comments in chat.
We do. There are lots of comments in the chat. Let me start at the beginning of them. Can I ask, do you ventilate all your babies up to 30 weeks? Was that what we were hearing?
Sorry, one more, please.
Yep. So, a question about ventilated babies. Do you ventilate all your babies, or do you use a lot of CPAP?
CPAP か、どんな風に、マネジメントしてますか？人工呼吸器。どんな風に？どっちが多いですか？ CPAP と。CPAP.
CPAP.
Yeah. Kids say they usually use CPAP less than 30 weeks infant.
So CPAP. Thank you. Okay, I'll start going through some of the questions here. And I guess we're starting, the initial ones were all about head in the midline position. So you said that you don't move your babies for 72 hours. You don't move position and keep the head in the midline but you move the mattresses.
72時間
うんうん
はまっすぐに
はい、
して
yes,
絶対動かさないっていう感じですか？
yes. 絶対動かさない。絶対、動かさないですね。
どんな時に動かす？
Is that common? That's common across Japan to use this method?
Sorry, wait a minute.
Yeah, that's okay. Brett's kindly put a Cochrane review into there, looking at that, which is really good. Do you want to stop screen sharing if you've got no more slides and we can all chat? And then you can see everything better. Perfect. Great.
チャットが届いてない。動かさ
You're
な
looking
い
at the questions. So there's a systematic review which Brett's put into the chat, looking at head midline position for preventing the occurrence of germinal matrix interventricular hemorrhage. I think many units would turn the baby side to side. And Julie and I were talking about this, but try to keep the head in the same position. But really interesting that you use the mattresses to change position and to decrease pressure injuries. Another question that's in here, or another comment, was you don't use heel pricks, you use venipuncture rather than heel pricks. Is that correct in your tiny babies? Yeah.
Bloods? どっちが普通？
heel sticks,
Yes. Do you use heel sticks?
mainly.
Yes, you do use heel sticks, or you use venipuncture?
No, heel stick is
Heel
made.
sticks.
Yeah.
Right. Can I ask another question? Do you use topical emollients with your tiny babies? So creams or oils or emollients on the tiny babies? Did you understand? I could.
Yeah, we use cream.
You use cream? What creams do you use?
Yeah, after the skin condition is stable.
So initially you just use humidity? Is that right?
Sorry, one more time, please.
You use humidity and then creams at what age?
Ah, すいません、埼玉医大の難波です。多分出生時に22、3週の子に、22、3週の子に保湿剤とかクリームとかベタベタに塗るかどうかっていう話で、多分塗らないですよね。
そうですね。出生時は塗らなくて、
After outside of incubator, she said they use these creams.
Right. Thank you. One of the comments here is that they have lots of trouble with skincare. If you look at the questions in the chat with them, and nothing seems to stick. They see lots of skin breakdown and infection from Louise. Any advice on how to get things to stick? You don't use ECG dots. I heard that was interesting. You just use a saturation probe with silicone. Do you have any problems with anything sticking to the baby if you're putting in UVCs?
So what does the stick mean?
The tapes and things attaching to the baby. So things like the taping all falling off.
Yeah. That is not sticky. We use the ECG monitor with a jelly, like ultrasound jelly.
Mm-hmm.
So, and then after that, we can use the sticky one after the baby's skin stable.
Right.
Yeah, not use the sticky one. And after delivery, the baby, we use the jelly with the ECG monitor or EEG monitor.
Mm-hmm.
So, and then after the skin, the baby's skin is stable, we can use the sticky monitor.
Thank
Right?
you. Yeah, thank you. That's great. There's a request from Jan. Could you please show the ventilation slide again, Keiko? There's a lot of interest about when you change from non-invasive to non-invasive ventilation. Would you be able to share your screen and go back to the ventilation slide?
Okay.
Thank you so much. Lots of questions here.
お、sorry. これか。これ、スライドショー、これ、この人どうやって消しますか？
あ、でもいいんじゃないこれで。
先頭から開始が、どこか。
あ、何？
スライドショーしたいんですけど、最初になっちゃうんですよね、これ。
Is this slide? Alright?
Did you have one before that?
一個前。
これか。
Respiratory management in SIMV mode.
あ、OK。
Okay, so are all your babies in SIMV mode until 1 to 2 weeks after birth?
Yes.
大体そのぐらい。
And so you don't switch to non-invasive CPAP till about 30 weeks. Is that correct?
Yeah.
I think that was the questions that were coming up here.
Sorry, one more time, please.
Okay, so you keep your babies ventilated until they are 30 weeks gestation. Is that with all babies?
10週までの人は全部 SI で、
いや、depends on baby condition なんだけど、
Because we certainly use a lot of CPAP and we have very few ventilated babies or if they're ventilated for very short periods of time. Do you have challenges with chronic lung disease, bronchopulmonary dysplasia in your outcomes?
Yeah.
That was one of the other questions, I think, here.
It's I guess it depends on neonatologist's opinion. How about you, Dr. Namba? Some hospitals use SIMV, but some CPAP or NABA or high flow, many it depends on condition or neonatologist's opinion.
I think the practices around the world are really interesting. It's so interesting to hear.
This enjoy. So,
hello, this is Ohashi from Ohtsuka Hospital.
Yeah.
Welcome.
I'm neonatologist, and I think the respiratory management is depending on the baby's condition. if the baby is born around 22 to 25 weeks or so, usually we have to prevent IVH. So within 3 or 4 days, we usually use SIMB or IMB for patients. And after that, gradually CLD, bronchopulmonary disease is increasing. So usually we have to switch to HFO mode. And after that, if the baby can digest milk and body weight is increasing, we tend to think about the challenge, which is we change the mode to SIMB again, and we see the status of respiratory of the babies. Then we can think about the extubation. So it's usually around 30 weeks, I think.
Thank you.
Right. Practices, I think, are very different. Brett, did you want to come in and talk about practices in Melbourne?
Thanks, Karen. Thank you very much to the amazing Japanese guests and all of the information they've provided. This is absolutely fascinating from all of us down here in Australia. And it's really, as Karen said, fascinating to see how differently we do things with outcomes that somewhat vary, but also not so much. And you know, this issue of mechanical ventilation is one we're really grappling with, and whether these tiniest of babies need to stay on the ventilator. But it is hard to envisage in our practice how leaving a baby on the ventilator for 8 weeks, for example, before even trying off would not result in very severe evolving chronic lung disease. And yet, when we look at the outcomes from Japan, the BPD rates are very impressive. So it's just something to get our heads around. But yeah, thank you again to the speakers. Wonderful.
Thank you, Brett. Yes, it is really interesting because your outcomes are really good in Japan, and we are interested to learn from you and how you're actually managing the babies. I'm interested in your humidity. You go up to 90% humidity for your tiny babies, and you keep them in that humidity for 2 to 3 days and then start coming down, or what do you normally do with humidity? How do you wean the humidity?
Yes. We keep the humidity up to more up to 90%.
90%, yes.
Day 2 or 3. Yes, day 2 or 3. Yes.
Do you have any problems with 90% humidity with rain out or inability to see in the incubator?
Yes. Rain out. Yeah. We have to wipe between.
Yeah, quite a lot. You have to wipe it a lot. Yes. Yeah. Great. There was a question earlier about giving ISOC, the colostrum, to the baby with the cotton tip, and one of the people here is saying that they use a syringe to give ISOC. You use cotton buds?
初乳は綿棒を使うんですかという質問です。
Yeah, たまに。She said sometimes use syringe.
Sometimes use syringe, sometimes use the cotton buds. Similar. Thank you, Dr. Namba. Yeah, great.
Maybe cotton swab. Yeah.
There are various comments. Luke's put in the chat that Sweden were routinely ventilating under 25 weekers to at least 28 weeks. So lots of differences around the world. Any other questions from people? Feel free to please unmute and ask Miki and Keiko a question. I'm interested in kangaroo care, Miki. Kangaroo care. So kangaroo mother care you do for your bigger babies, but not the little ones. Is that correct? So it's after 32 weeks? How early gestation would you do kangaroo care? I've written it in the chat. How early gestation would you do kangaroo care? In our unit, we do kangaroo care and get the babies out skin to skin quite early, and certainly less than 32 weeks and within the first day of life for many of our babies.
Can I talk to?
Yeah, please do.
Yeah, our facility, it depends on the baby's condition, but in the baby who is incubated, but in the ventilation, using the ventilation, we can discuss about if the baby can do the kangaroo care or not. And then we decided to do. So it's not gestational age.
On the condition of the baby.
Yeah.
Great.
Even the baby using the ventilation. So, but at least not use the angular line. So because if the angular line
comes out,
it comes out, it is dangerous. So we just keep the baby's safety.
Thank you. Yeah. Louise has got another question here. When on more feeds, how do you manage these? Do you give continuous feeds, bolus feeds, hourly or too early? So interested in how you feed the tiny babies. So it's, do you give continuous feeds or do you give bolus feeds the milk to the baby? Is it, there's lots of different ways to give milk.
Also, can I talk to?
Please jump in, Miki.
Sorry.
Welcome.
It also depends on the baby's condition. We can the first few days we just use the colostrum with the swab bath, and then after that we can use the colostrum bolus. Not use the milk pump device, and then after that it depends on the condition, but we use the milk machine, and it start from the 30 minutes, and then and 1 hour, 2 hours, and if the baby cannot tolerate the milk volume, we just use the ED tube and then continuously use.
Mm.
Mm.
Yeah. There's lots of different practices here. Some units will have them on syringe pumps, some units will bolus them, and some units will use gravity. So
Yeah.
Miki, Konishi this time, Miki. Any thoughts from you on looking after the tiny babies? Why do Japan do so well? The nursing care must be very good, and you must teach the nurses very well. Your thoughts? Your nursing ratios are 1:3, but you work in pairs, which is very interesting that you work in pairs to learn from each other. That's a really interesting and supportive way to teach. Has that always been your practice? Oh, I can't hear you, Miki. Maybe you're muted.
Wait, sorry.
There you go. I wondered why I couldn't hear you.
Okay. Partnership nursing system is not common in NICU in Japan. It is it's common in not NICU or such as some ward in hospital. Most of NICU nurses shortage. We do 1 to 3 is patient to nurse ratio. It is it's not full.
So that's 1 nurse and 3 ventilated babies.
Yes, yes. Actually, I don't know why in Japan it's good for tiny baby. It is
Right.
But neo and nurses is good communication and in Japan. It is very important factor to save tiny baby, I think.
And do you have nurses, neonatal nurses shortages in Japan like we do here? 1 nurse to 3 ventilated babies is a very high ratio for us.
Yes. What is ratio in Australia or
ratios in Australia? Generally, we would try and have 1 nurse to 1 ventilated baby. Maybe Linda, what would you do in Brisbane?
We have 1 to 2, but any babies that's born 25 weeks and below is 1 to 1. It's 1 to 1 for the first 24 hours.
Yeah, we would be something similar. But Jennifer's saying, but you work in pairs. Keiko, you mentioned you work in pairs. Does that mean that you have a senior nurse and a junior nurse at all times? So it's 2 to 3? Or is that, are you reading that wrong?
Sorry, I don't know.
I guess that depends if you've got people training.
Yeah,
And we do 1 to 2. Yeah, if you have a look on the chat, there's lots of different ratios between 1 to 1, 1 to 2. And don't routinely sedate. That's from Karen Malcolm. We don't know. I mean, routine sedation. You routine sedate your babies with fentanyl. I think Keiko said that on her slide. Again, interesting practices. This is fascinating to hear, and it's actually fascinating in the chat. Oh, thank you, Dr. Kasudo. One nurse takes care of 3 infants, but not all are ventilated. Wow, still quite high, still higher than here, though. I think in general, we try to do 1 to 1 for ventilated, and 1 to 2 for CPAP. Royal Brisbane 1 to 2 and 1 to 1 for the first 24 hours for a tiny baby. I think we're very similar, and I think that's similar in Melbourne as well. Brett or Jennifer, is that similar in Melbourne? Yep, great. Oh. Well, we are coming to the end, but are there any more questions for for Miki and Keiko? I think there's a lot of interesting comments in the chat. There's a manual that's been published by Dr. Kasudo. That's great. Any other comments that people would like to unmute and talk about? I've got 2 new messages down here. What have I got? Another question for you guys. They would like to know your fluid philosophy. Louise, would you like to unmute and ask your question? I think maybe expand a little bit on that.
Hi, yes, thank you, Louise here in Melbourne. I'm one of the neonatologists. We really struggle with these babies to know how much fluid to give them so that they don't get dehydrated, get very high sodiums, but also don't get hyperglycemic. It's a very difficult balance, and we really struggle to get that balance right. So I'm curious to know how you manage that.
So Miki, Keiko, I think what level fluids are your babies on in the tiny ones in the first few days?
Maybe Dr. Fumi and Dr. Satoshi could help there.
Yeah, I'm Dr. Namba from Saitama Medical Center. I think in Japan, basically, 50 to 80 milliliter per kilogram is given at the first, and gradually going up to, I don't know, 100 to 130. But I heard it depends on the institution or countries. I heard in the Iowa that they are not using closed incubator, so they give 150 or 200 milliliter per kilo at first. So I don't know, the best volume is, I don't know what volume is best, but in Japan, basically 50 to 80 milliliter per kilo per day at first.
Thank you. Again, I think there's lots of differences around the world. Dr. Kasudo, Dr. Satoshi is 80 to 100 ml per kilo for the first day, then increase 10 to 20. If you use high humidity, you do not need the high volume. And Louise is saying they use incubator high humidity 8 to 90%, but still need to give towards 200 mils per kilo per day, and they still have issues with hypernatremia. Really interesting, and interesting the practices with humidity as well from the different levels. Yeah, and Jan's agreeing with that as well. So very much looks like it depends on the humidity levels too. Thank you all. Few more minutes, last questions. Any last questions for Miki or Keiko? No, I don't see any hands raised. I don't see anything in the chat. I'd like to thank you both for coming and for speaking to us and sharing your experiences from Japan. We are really interested, and it's great to be able for all of us to learn from each other. And I want to thank everybody in the chat. It's been a very, very busy chat with lots of people putting comments and their own practices up there. So again, it's really, really interesting to find out what everybody's doing. We have recorded this because we know not everybody could attend that wanted to. So they will be able to actually listen to this recording. And I'm sure if you have more questions, you could reach out to Miki or Keiko or Dr. Satoshi or Dr. Namba. That would be fantastic. So I might close. We have 2 minutes left. No last questions from everybody. So you've got 2 minutes back in your day. Thank you all for coming to the Royal Hospital for Women webinars.
Thank you, Karen. Thank you.